Well, they can do better by just getting the healthy people who don't have insurance claims. It's been a good strategy. The ACA is going to change that. It's going to actually reduce the advantage with insuring healthy people in those individual and small group markets. There are other factors that insurance companies compete with each other on. Membership to a degree, underwriting, whether they're self-funded, whether or not you can spread your administrative costs, organizational efficiency. It is an industry that favors size. Surprise, right? Anthem can take advantage of economies of scale that even Harvard Pilgrim can't. And Harvard will admit that. They've got to offer something unique. Even though they're large in New England, they're nothing like Anthem National. There are return on investments. Insurance companies do something with your money before they spend it on claims. And then there's, well, customer service, but never as much as we would like to see. So there are some areas where they compete, but the main areas have been medical claims costs and the insured population health status, and closely related to those without a country. So we talk a bit about kind of the networks and this contracting and these good deals or bad deals that they do or don't get. And there certainly has been a lot of attention around Anthem's narrow network. Because historically, insurance has included most of, if not all of the hospitals in the state, almost all of the time. In fact, most of the doctors have almost always been in the network. But this is a bit of a new approach. A number of years ago, 15, 16 years ago, New Hampshire passed a law that said an insurance company must have an adequate network in the state. Adequate was a floor, a very basic network, sort of the worst case scenario. And it basically had to do with how far you had to travel for hospital services or certain specialty care services. And basically it said 45 minutes to an hour. If you can get there within that amount of time, then the network's probably adequate. Those rules, we have a law and then we have rules, and both are referenced there. The rules are the real specifics of what would otherwise be in the law. They are in need of updating. And it's kind of interesting because in the spring I kept telling people, I'm going to update the network adequacy rules this summer. It's one of the things I need to do. It's on the agenda. And then, of course, it became hugely relevant this fall, so I can't decide if I'm unhappy I didn't update them or happy that I let somebody else sort of deal with the issues around it. Nevertheless, we need to recognize the healthcare system is changing. It's evolving, unrelated to the ACA. So we've got a number of things going on. We've got an investment in community health centers, a great place to get primary care. We've got increased use of what we call mid-level providers, nurse practitioners, physician assistants, health coaches, community health workers. You don't always need to see a doctor for everything that you have a problem with. We use telemedicine. You don't need to travel all the time, particularly if you can get access to telemedicine services. We've got hospitalists that are filling in for patients who are treating patients in a hospital setting when otherwise the primary care provider would have had to go into the hospital to see those patients. That's going to free up the primary care provider a bit more. We've got urgent care centers and other walk-in clinics. You may see an emergency medicine physician in there. You may see a family practitioner. You may see a midwife. The point is you've got increased capacity within the system treating patients in different settings. And this is a natural progression. We've got accountable care organizations. Michelle talked quite a bit about that, trying to make more efficient use of our resources. We've got many hospital services being provided in non-traditional settings. In fact, down the road, you begin to wonder what services in a hospital couldn't be done in another setting, perhaps more efficiently. So the way we think about a hospital, I think, is going to continue to evolve and change. Even when we think about good quality health care, it's often done in places where people have a lot of experience with it. I mean, you're not going to get a lung transplant at Concord Hospital. You're going to go to Boston or something like that because they do more of it. Even to the extent we talk about cardiac surgery, is that something that's appropriate at Concord Hospital? You probably don't want it in the North Country, but maybe going someplace like CMC is really a good place to go. So when we think about where we get health care,